we have most people in here, so we'll begin the webinar. So, on behalf of Synzyme, thank you for joining today's webinar. The list of attendees from across the globe emphasizes the significance of this clinical topic. We're really glad you could join. We'd also like to thank the Anesthesia Patient Safety Foundation for partnering on this patient safety issue. A few housekeeping items. The program will be consisted by a presentation by Dr. Murphy, followed by a Q&A panel discussion from both he and Dr. Brull. Everyone will be muted, so if you have any questions throughout the program, please submit them via the Q&A icon at the bottom of your screen. Those questions will then be addressed to our panelists during that discussion. The webinar will be recorded if any of your colleagues would like to watch at a later point. Instructions to access that video will be included in the post-webinar survey or communication. So without further ado, I'll turn it over to someone who, while he needs no introduction, is one of the foremost experts in neuromuscular blockade monitoring and authored over 400 papers on the topic. In his clinical practice, Dr. Sorin Brull is a professor at the Mayo Clinic College of Medicine. With that, I'll turn it over to Dr. Brull.
Good morning, everybody, or good afternoon. First of all, I'd like to also thank Synzyme and Mr. Neil Smith for the time and effort in putting this webinar together. I know we've been working on it for a number of days. And of course, the webinar would be impossible without Dr. Glenn Murphy's participation, so thank you very much for being here. Most of all, however, I'd like to thank you, the virtual audience, for enrolling in this webinar. It's something that I think we will unfortunately have to get used to as we're working toward a new normal. So right now, it's my distinct pleasure to introduce to you Dr. Glenn Murphy. Again, I don't think that he needs any introduction either. He is the Jeffrey Vender Chair of Anesthesiology Research and Education at the North Shore University Health System and a clinical professor at the University of Chicago Pritzker School of Medicine. Thank you very much to everybody for being here. Dr. Murphy.
Well, thank you so much, Sorin. I really appreciate the kind introduction. And I'd like to thank everyone who's attending at this time. And what I'll be talking about today is how we can use our neuromuscular management practices to transform our outcomes after surgery. Next slide. I do work as a speaker for Merck, but I will not be discussing any off-label use or investigational use of medications in my presentation. Next slide. I'd like to talk about three things today. First, briefly talk about what the risk of residual block is in our clinical practices. Second, and far more importantly, what are the clinical implications of residual block? Meaning when someone gets to our PACU with a residual block, how does that affect their outcomes after surgery? And third, talk about the impact of monitoring on the risk of residual block in clinical outcomes. Next slide, please. I really believe one of the biggest things we do which harm our patients is leaving them with residual block in the PACU. And this is something a lot of people who do research in this area, I think, would agree with me. This was an editorial written by Sorin Brull stating that in the United States, approximately 112,000 patients annually are at risk for adverse events associated with discharge from the operating room with residual neuromuscular block. Next slide, please. What's surprising to me is that a lot of our fellow clinicians don't believe this. This was a survey that was sent to a large number of anesthesiologists in the United States and Europe, asking, do you ever see clinically significant residual block in your practice? And 80% of the European respondents and 90% of the respondents in the United States said they never see this in their clinical practice. Now, this is really remarkable to me because I see residual block in our clinical practice every day. So how do you really account for this difference? I think it's because I'm using quantitative monitoring in my practice. Unfortunately, most clinicians in the United States and Europe aren't routinely using quantitative monitoring in their practices. And I think it's kind of like the old saying, if you don't take a temperature, you don't find a fever. Well, if you're not using quantitative monitoring, you're not going to detect residual block. So when that patient's in the PACU getting into trouble, their airway obstructing, their oxygen is dropping dramatically, the nurse is really struggling to get them to breathe, we often say, well, you know, the patient's 400 pounds, the patient has sleep apnea, which may be true, but those patients, if you leave them with residual block, are the ones who are likely to get into trouble. And again, unless we're using quantitative monitoring, we're not going to know that it's present or not. Next slide. Well, how is residual block defined? Again, I think most of the audience know this. When I was a resident, I was taught that residual block was defined as a train of 4 ratio of less than 0.7 measured with quantitative monitoring. And where that really comes from is data from Ali's lab at Mass General in the 70s. And basically, they took these poor medical students, gave them 20 bucks, partially paralyzed them, and had them perform pulmonary function tests. And they found that pulmonary function tests were acceptable at a train of 4 ratio of 0.7. However, if you look at studies that have been performed over the last 20 years, you really need this train of 4 ratio to recover to 0.9 or greater before you can really safely extubate the patient in the operating room. And that comes from a large number of studies, volunteer studies and in clinical trials. These studies show that subjects with train of 4 ratios less than 0.9 have impaired pharyngeal function. They have a higher risk of hypoxemic events. They have airway obstruction. They have an increased risk of aspiration. They have prolonged extended times in the PACU. They have an increased risk of pulmonary complications. A whole list of bad things can happen to patients if we leave them with residual block in PACU. I'll be talking about a number of those studies later. Next slide. Well, how frequent is residual block in our clinical practices? Well, the first study was performed 4 decades ago by Dr. Vidby Mogensen and colleagues, and they found that 41% of their patients were getting to the PACU with residual block. Well, if you look at studies that have been performed in the intervening 4 decades, they pretty consistently show that somewhere between 30 and 60% of our patients are getting to the PACU with residual block. Now, again, most people think this never happens. It's very, very common in clinical practices. I'd just like to point to 3 studies that were recently performed, the RECITE studies. These are well-designed studies performed in Canada, China, and the United States. This is a Canadian study. This is a prospective observational study looking at the incidence of residual block at 8 Canadian hospitals. And again, they looked at relatively healthy patients undergoing a single procedure abdominal surgery, and they measured train of 4 ratios right before they took the tube out and on arrival to the PACU. And again, I think it's important that measurement before we extubate the patients, because we really want to have full recovery of all our upper airway function before we do that. So in this study, they enrolled 302 patients. Rocuronium was used in the vast majority of cases, which is true in most North American practices. And neostigmine reversal was used in 3/4 of the cases. What they found, the incidence of residual block was 64% at extubation and 57% at PACU arrival. Next slide. This is a RECITE China study. And what they found in this study, that the incidence of residual block was 58% before extubation. So pretty similar to what they found in the Canadian study. Next slide. And this is the most recently published RECITE study. This comes from the United States. This was a prospective observational study looking at the incidence of residual block at 10 US hospitals. It was a combination of academic and private practices. Again, looking at the same patient population as the previous studies. And they measured train of 4 ratios immediately before they removed a breathing tube. In this study, 255 patients were enrolled, and nearly all the patients in this study received a reversal agent. Yet despite receiving that reversal agent, 65% of these patients had residual block right before extubation, and 31% of these patients had severe residual block. So we can see over time, this is still a very persistent problem in our clinical practices. And I think, looking at all these studies performed over 40 years, the data is pretty convincing that a lot of our patients are getting to the PACU with residual block. Next slide. Now, I think the bigger question is, so what? We're not saying 40% of our patients aren't getting into severe problems, but I think a certain percentage of those patients who have residual block will get into problems because of that residual block. So what does that residual block mean? I think there's 2 lines of evidence we can look at to get those answers. We can look at these database studies. These are large database or observational investigations looking at the association between how we manage neuromuscular blockade in the operating room and adverse outcomes. Now, the advantage of these types of studies, we can look at some of these rarer, less common events because they're very large size. And then we have the second line of evidence, or the clinical studies. And these are studies where we look at patients when they get to the recovery room, we put a quantitative monitor and we look whether they have residual block or not. And then we very carefully follow them to see what are the implications of residual block in the PACU. Next slide. Well, I'd like to start by just highlighting a couple of these database studies. There have been a large number of these published over the last 10 years. There's some interesting data that's come out recently showing if we fail to reverse neuromuscular blockade, our patients are at risk for adverse outcomes. Now, what's interesting, only about 30 to 40% of anesthesiologists in the United States and around the world routinely reverse neuromuscular blockade. I think this is potentially a dangerous practice. This is data that came from Vanderbilt University, and they were looking at the association between neuromuscular blocking agents, reversal agents, and the risk of postoperative pneumonia. Now, what they found in this study is that patients who received the muscle relaxant had a higher risk of having postoperative pneumonia. That's really not too surprising. There have been a lot of previous studies that have shown that. But I think more importantly, they showed that patients who received the muscle relaxant and who were not reversed, they had a 2.3 times higher risk of developing postoperative pneumonia. So again, I think this is pretty good data showing this, failure to reverse can have an effect on postoperative recovery. Next slide. Now, shortly after this study was published, this investigation came out in Anesthesia and Analgesia, and it's surprisingly looking at pretty much a similar outcome variable. This study was looking at the association between using muscle relaxants, reversal agents, and the risk of postoperative morbidity or mortality. Now, this was a retrospective study involving over 11,000 non-cardiac patients from 5 VA hospitals. In this study, almost 9,000 patients received the muscle relaxant. And of these 9,000 patients, 2,000 of these patients were not reversed. And now, their primary outcome variable they were looking at in this study was respiratory complications, which they defined as failure to wean, reintubation, or pneumonia. So rare, these things that we don't commonly see, but again, very serious outcome measures. Now, what they found was that patients who got muscle relaxants had a higher risk of these respiratory complications. And that's, again, not surprising. But again, they found that patients who received a muscle relaxant who were not reversed had a significantly higher risk of these major adverse respiratory complications. And this persisted through all the analysis they did in the study. And in fact, they found a marginal increase in 30-day mortality in patients who were not reversed. So again, I think this is additional supportive data that we should always reverse our patients unless we have a quantitative monitor that tells us we fully recovered. Next slide. Now, this is an interesting study that came out of Matthias Eichermann's group at Mass General. Now, this was a retrospective cohort study examining the association between residual block in the PACU and hospital cost, ICU admission rates, and hospital length of stay. So these are, again, very important outcome measures that we want to basically be looking at. What's unusual in this database study is they actually had train-to-4 ratio data on patients. They collected data from a previous study, so they actually had data whether patients had residual block in the PACU or not. This is actually the only database study I think that I've seen that has had this information. Now, they looked at data on over 2,000 adult patients undergoing surgery with general anesthesia. Now, in this study, 21% of the patients had residual block, and this is traditionally what we've seen in studies from this institution. Now, residual block was not independently associated with increased hospital costs, which was the primary outcome measure, but they did find that patients with residual block in the PACU had a 3 times higher risk of unplanned ICU admission compared to those without residual block. Again, that's a very important thing to be concerned with. Again, we know the cost associated with ICU stays. And they found there was a trend towards increased hospital length of stay in patients with residual block. Okay, next slide, please. Now, recently there have been a number of studies looking at the association between choice of reversal agents, Sugammadex or Neostigmine, on outcomes after surgery. This is one study that looked at that. This was a single center retrospective observational study of the effect of Neostigmine and Sugammadex on 30-day unplanned readmission rates, hospital length of stay, and hospital cost. Again, we're very concerned about these 30-day unplanned readmission rates because oftentimes insurers will not reimburse us if someone has a 30-day unplanned readmission rate. Now, they looked on data on over 1,400 patients. And of these 1,400 patients, about 25% got Sugammadex and 75% got Neostigmine. These were patients undergoing major abdominal surgery between 2010 and 2017. What they found then, when they looked at the patients who received Sugammadex compared to the patients who received Neostigmine, the incidence of 30-day unplanned readmission rates was 34% lower, hospital length of stay was 20% shorter, and hospital charges were 24% lower. So all were statistically significant. Now, patients who get Sugammadex, we know if it's dosed appropriately, should only have a risk of residual block of maybe 1 to 3%, versus Neostigmine, which we know can be anywhere from 20 to 50% of patients. So even though we don't have residual block data, it suggests that patients with residual block in a PACU can have these outcomes that persist even after they're discharged from the hospital. Next slide. Now, this study is just available at EPUB ahead of print, but it comes from Dr. Ketterpaul's group, the MPOG group from Michigan. And again, I think this group does some of the best database research out there. They do excellent studies. This was a study looking at choice of reversal agents, Sugammadex versus Neostigmine, on the incidence of postoperative pulmonary complications. This is a stronger study. This is a multi-center, 12-hospital observational matched cohort study. And they looked at adult patients undergoing elective inpatient non-cardiac surgical procedures over a 4-year period who received the muscle relaxant and reversal agent. Now, they defined their primary outcome measure as a composite outcome measure of postoperative pulmonary complications, defined as pneumonia, respiratory failure, or other pulmonary complications, which they defined. So in this study, they had over 22,000 patients who received Sugammadex who were matched with 22,000 patients given Neostigmine. So you can see there's real strength in a very, very large study like this. What they found in their multivariable analysis was that Sugammadex use was associated with a 30% reduced risk of these pulmonary complications, a 47% reduced risk of pneumonia, and a 55% reduced risk of respiratory failure compared to patients given Neostigmine. So again, we know that patients who are given Sugammadex have a much lower risk of residual block in a PACU, and that likely accounts for these improved outcome measures. Next slide. I'd like to move on to the clinical studies. And again, these are studies where patients get to the PACU, we put a quantitative monitor on them, we measure whether they have residual block or not, and then we follow these patients for these adverse postoperative events, which include adverse pulmonary events such as hypoxemia, airway obstruction, and postoperative pulmonary complications, a prolonged PACU length of stay, and unpleasant symptoms of muscle weakness. Again, part of the reason I think clinicians don't recognize residual block is happening in their practice is we drop our patients off in the PACU, then we go back and start our next case. It's our PACU nurses who are dealing with our problems, or our patients nurses on the floor who are dealing with these patients who are developing pneumonia later. We don't see it because we're not following the patients. So it's sort of out of sight, out of mind. We're just not aware of the downstream effects that we see with residual block. Next slide, please. This is a study we did at our institution, and we know that older folks from previous data are at higher risk of residual block. So we would basically, we're looking at the risk of residual block in the elderly patient population and some of the clinical implications of this residual block. So we prospectively collected data on a cohort of younger patients, 18 to 50, and a cohort of elderly patients over the age of 70. When these patients got to the PACU, we measured whether they had residual block or not, defined as a 3-to-4 ratio of less than 0.9. And then we very carefully actually followed these patients from the time the tube came out in the operating to the time they were discharged from the hospital for any adverse events that might be related to this residual block. That includes airway events, unpleasant signs and symptoms of muscle weakness, hospital length of stay, PACU length of stay, and et cetera. Next slide. What we found was the risk of residual block was about twice as high in the elderly patients, 58%, versus younger patients, 30%. And again, that wasn't a big surprise. We know that elderly folks had a much higher risk of residual block. Every time you give a dose of muscle relaxant, it lasts longer and longer in this patient population. They don't metabolize it as well. They don't eliminate it as well. And they're more sensitive to muscle relaxant. So there's lots of pharmacokinetic and pharmacodynamic reasons that the elderly folks are at a higher risk of residual block. Now, when we looked at all this bad stuff, airway obstruction, hypoxemic events, signs and symptoms of muscle weakness, postoperative pulmonary complications, increased PACU in the hospital length of stay, they occurred more commonly in the elderly. Well, that's not really surprising. We'd really expect to see that. But then when we took that elderly cohort of patients and we looked at those with residual block and those without residual block, all that bad stuff happened with a higher frequency in the group that had residual block. So not only are elderly patients at higher risk for residual block, but if they have residual block, they're at higher risk for complications related to residual block. So we have to manage these patients very, very carefully, I think, in the operating room. And that's something I always really try to teach my residents. Next slide. This is a study looking at association with residual block in the PACU and adverse events in the PACU. There's a large multi-center study from Spain, enrolled 763 patients from 26 centers. Again, when they got to PACU, they looked whether they had residual block or not, and they followed them very close in the PACU for any adverse events. Now, they found that 27% of patients had train to full ratios less than 0.9. Again, we seem to see this similar kind of number around the world. Now, in this practice, these practices, only 50% of the patients were monitored intraoperatively, and reversal was used in 62% of patients. And that's a common type of practice in Spain, and we see very similar practices kind of around the world. People aren't routinely monitored, and people aren't routinely reversed. But with this type of strategy, they found that the patients who had residual block in the PACU had a 2.5 times higher risk of adverse respiratory events. And more importantly, they had an increased risk for reintubation. And again, that's important because data from Matthias Eichermann's group has shown that these patients who get reintubated in the PACU have a 90-fold increase in mortality. We all know that those patients oftentimes don't do well. So we know, this is a study along with others that showed that patients who have residual block in the PACU may be at increased risk for reintubation. Next slide. This is a similar study. It was a prospective observational study looking at these risk factors for adverse respiratory events in the PACU. Now, they studied 340 consecutive patients. They looked at a large number of preoperative and intraoperative predictors. Now, these adverse respiratory events occurred in 20% of patients. Again, these type of things are not uncommon when you look for them. They found when they did their analysis, these adverse respiratory events were more common in patients who received muscle relaxants. Again, we see that again and again. In patients receiving neostigmine, and this could mean one of two things. Dr. Eichermann's group has shown that patients who get neostigmine when they have full neuromuscular recovery have an increased risk of having paradoxical muscle weakness. But I think more likely explanation is the people who are receiving neostigmine are patients who are more likely higher risk, the older patient, or the patient at the end of the case and you only have one twitch and you're giving neostigmine to those type of patients. I think it's more a marker of those patients who are at higher risk. And these adverse respiratory events are more common in patients who had residual block. And in fact, when they did their analysis, the single biggest factor by far that predicted these adverse respiratory events was the presence of residual block. Patients with residual block had a 6.5 times higher risk of having these adverse respiratory events. So again, we're seeing this clear association between some of these bad things that happen in the PACU and residual block. Next slide. Now, this is an interesting observational study, and I think it's important because what they did is actually closely follow these patients for major respiratory complications after anesthesia and surgery. Now, a lot of these studies have focused on the early recovery period, but this is a study that actually followed patients at the time of discharge of the hospital. Now, this is a prospective observational study of 558 patients. They looked at 4 groups of patients: those who got cis-atracurium with no reversal, those who got cis-atracurium with neostigmine, those who got rocuronium with no reversal, and those who got rocuronium with Sugammadex. Again, within this anesthesia practice, those were the common practices that were done. Now, when these patients got to the PACU, they put a quantitative monitor and they looked whether they had residual block or not. And then they followed these patients in the PACU for what they called minor critical respiratory events, which were airway obstruction, hypoxemia, and things like that. But more importantly, they closely followed these patients until they were discharged from the hospital for major respiratory complications, which they defined as pneumonia or atelectasis on the chest x-ray. Okay, next slide. Now, when they looked at the patients who got no reversal or neostigmine for reversal, the risk of residual block was between 30 and 35%. When they looked at those who got rocuronium with Sugammadex, the risk was 1.2%. Again, consistent with what we see with the literature. Now, they found that patients who had got no reversal or neostigmine reversal, they had a much higher risk of having these adverse respiratory events in the PACU. But more importantly, when they followed these patients until they were discharged from the hospital, patients who got either no reversal or neostigmine reversal had an incidence of these major respiratory complications, again, that's pneumonia or atelectasis on a chest x-ray, of between 7.2 and 9.7%. Versus those who got rocuronium Sugammadex, that risk was 1.1%. Now, we don't want to think what we do in the operating room affects these patients having pneumonia or atelectasis on the x-ray. That's something a downstream effect, but it really does. And I think this study shows that those patients who had residual block in the PACU were at significantly higher risk of these, basically these significant adverse respiratory events. Next slide. Patients who have residual block spend a lot longer in the PACU. This is a study that came again out of Matthias Eichermann's group. We've done studies in our group, we've shown the same thing. This was an observational study involving 246 consecutive patients. They measured train of 4 ratios and followed how long they stayed in PACU. 22% of the patients had residual block in the PACU. And those patients that had residual block took 75 minutes longer to meet discharge criteria and 80 minutes longer to actually be discharged. That's a big difference. And think how that can hold up the flow of your patients in the operating room. And again, I think those patients with residual block are those ones who are just sort of laying there and never seeming to wake up because they're partially paralyzed. Next slide. Which kind of ties into a study that we did. When you ask patients if they ever had problems with previous anesthetics, one thing I commonly hear is, it took me a long time to wake up. Well, next time you hear someone say that, ask them, well, what do you mean by long time to wake up? Oh, just I felt so tired, I couldn't hold up my head, and it was difficult to speak. Those symptoms are very, very commonly symptoms of residual block. I think the reason patients say that is because they're partially paralyzed. They're sitting around in PACU and just feeling weak. And it's a very unpleasant sensation. So we did a study, we hypothesized by using a quantitative monitor, we used the TOF-Watch in this study, by reducing the risk of residual block, which we know quantitative monitoring does, we should also reduce the risk of these unpleasant symptoms of muscle weakness. And we looked at 155 patients who were randomized to the TOF-Watch, a quantitative monitor, or just a standard peripheral nerve stimulator. They got extubated when they met all the standard criteria, but in the TOF-Watch group, they had to get to at least a train of 4 ratio of 0.8. Then we examined these patients for 16 symptoms and 11 signs of muscle weakness in the PACU in 20, 40, and 60 minutes later. We had them quantify the sensation of general weakness, which is unpleasant, just feeling that patients have. And we had to have them evaluate their quality of recovery at the time of PACU discharge. Next slide. Well, what we found was the risk of residual block was significantly reduced in the patients who got monitored with a quantitative monitor. We also found that the number of symptoms of muscle weakness was significantly less. These patients felt better. They felt less of this draggy, partially paralyzed feeling. Next slide. We found that people really complained about most of these, this feeling of general weakness and visual symptoms. And, we also found that the group that was monitored with a quantitative monitor, the overall weakness on a 0 to 10 scale was reduced by 50%. So patients felt significantly less of this general weakness feeling. And more importantly, people rated their quality of recovery at time of discharge from the PACU as significantly higher if they were monitored with quantitative monitoring. Next slide. Which is kind of a nice segue into our next topic, which is monitoring. Now, there are two types of monitors. There are qualitative monitors and quantitative monitors. And when we talk about qualitative monitors, what we're really talking about is a peripheral nerve stimulator. As Dr. Brull has spoken about in the past, it's really not a monitor. We're stimulating the nerve and looking at a response. We're sort of the monitor, but there's no actually monitor attached. It's a stimulator, but it's not a monitor. But we'll use the term qualitative monitoring because that's what's standardly done. Now, does this type of monitoring sort of impact outcomes after anesthesia and surgery? Next slide. We don't have a lot of data on this. We have a couple of small studies from the 90s. This is an example of one of the studies. In this study, 39 patients were randomized to train of 4 monitoring with a peripheral nerve stimulator or no monitoring. They found the risk of residual block was 47% of patients with no monitoring group versus 15% with a monitoring group. Again, if you look at that, that's a train of 4 ratio of 0.7 in the PACU. That was the standard definition at times. You can imagine the incidence is much higher if you raise that to 0.9. Next slide. This is a similar study, but they used double burst stimulation. Now, if you look in your nerve stimulator, there's that DBS button that nobody ever uses. But there's data showing that mode of monitoring is much more sensitive, is more sensitive in detecting residual block than train of 4 monitoring. You get 2 short mini tetanic bursts separated by 750 milliseconds. Because they're closer together, you may be more likely to detect fade when you're doing that. In this study, 60 patients were randomized to double burst stimulating monitoring or no monitoring in the OR. Again, in a no monitoring group, 57% of the patients had train of 4 ratios less than 0.7 versus 24% in the train of 4, I'm sorry, that should be double burst stimulating monitoring group. So you can really reduce the risk of residual block based on these small studies. But I think the title of this article really sums up most of what we believe as neuromuscular researchers about the benefits of using a peripheral nerve stimulator. Basically, that these monitors decrease but do not eliminate the problem of postoperative residual paralysis. Again, we don't have good large-scale studies. I think almost everybody who does research in the area would absolutely insist that using at least a peripheral nerve stimulator is mandatory. Again, quantitative monitoring would obviously be preferable. Next slide. Well, why don't these monitors work great in eliminating residual block? Well, what I was taught as a resident, if you see 4 strong twitches with no fade, we were fine to take out the breathing tube. Well, that's actually not true. And this is a study Vibi Mogensen did, and Dr. Brull's done some research in this area too. And they looked at the ability of anesthesiologists to detect fade using train of 4 stimulation at various levels of neuromuscular blockade. And basically what Dr. Vibi Mogensen showed and Dr. Brull showed is that you really can't see that fade unless train of 4 ratios are less than 0.4. So you may see 4 strong twitches at the end of the case and think, wow, things are okay, but you can actually have train of 4 ratio as low as 0.4 when you see no fade. So it's not very good. And that ties to nothing. All the tests we use to detect residual block are not good. 5-second head lift, there's been studies showing that almost 90+% of volunteers can hold a 5-second head lift at train of 4 ratios as low as 0.5. So basically all the tests we do at the end of the case, 4 strong twitches, no fade, squeeze my hand, hold my head up, none of that is very good at detecting residual block. The only way you can detect it is with quantitative monitoring. Next slide. So let's go to the next question. Does quantitative monitoring reduce the risk of residual block or impact clinical outcomes? Next slide. Well, for years, this is the only monitor we had as a standalone monitor, quantitative monitor, the TOF-Watch SX. If anyone in the audience has used this, I'm sure they've had similar experiences. It was not a user-friendly device in the operating room. This is an accelerometry technology. At the thumb, we have an acceleration transducer connected to the thumb. Again, it measures acceleration because force is equal to mass times acceleration by Newton's second law. Acceleration is proportional to force. Well, the problem with this device, it was pretty difficult to use. You had to secure the hand in a very particular way. The thumb had to move in the exact direction every time. You had to calibrate the device. You had to wait for a period of signal stabilization. It took so much work to get accurate data out of this that it really never caught on clinically. It was hoped when this was introduced, well, we finally have quantitative monitors. People have been asking for these for a long time. It never caught on because it just was a hard device to use. Next slide. Which goes to some of the new 2nd generation devices, which clearly are much better. Now, one of the problems with the TOF-Watch, as I mentioned, the thumb had to move exactly the same way every time. But when we stimulate the ulnar nerve, because of the complexity of the thumbs, sometimes the thumb moves in different directions, and you get goofy numbers, and people would put this on and say, this thing doesn't work. Well, this device can actually measure the movement of the thumb when it moves in those potentially other directions. So it gives, at least in my clinical experience, much more reliable results. Next slide. We did do a study where we actually compared, on one hand, we put the TOF-Watch SX and went through all that elaborate setup that I talked about. On the other hand, we put the TOF scan on and just turned it on and used it. We found the TOF scan correlated very well with the TOF-Watch SX with all that elaborate setup. So it works pretty well in the situation. However, one of the problems with this, you actually have to have the hand out, and the thumb has to be able to move freely, which is a problem with so many of our cases, the hands are tucked. Next slide. The GE machine has a module that you can plug into the machine and use two different types of technology. On the left, you see what's called kinemography, and that little device is placed between the thumb and the index finger. It has a piezoelectric element there that bends and generates a current and gives you a number. Unfortunately, this type of technology hasn't been particularly well validated. So we probably use more data on it. And this, from what I understand, we don't have GE machines. Again, it takes a little time to use this and learn how to use it appropriately. It also has an EMG cable that can be plugged in. So you can actually do EMG monitoring with this too. You can put on 5 EKG electrodes, stimulating, grounding, and sensing electrodes on the hand, and measure EMG with this. Again, unfortunately, this type of technology hasn't been particularly well validated. Next slide. Fortunately, we also have coming out portable EMG monitors. This is the Tetragraph, recently received FDA approval in the United States. And what it has, you see on the left here, is an electrode strip, which has stimulating electrodes and then a sensing and grounding electrode that you put on the hand. The idea is to make this as user-friendly as possible. Things have to be almost as easy to use as a pulse oximeter, I think, before anesthesiologists are going to accept them. So you basically put this strip of electrode on, you plug it in, and then you hit a button, turn the device on, hit a button, and get a train of 4 ratio. We basically are doing some studies with this device right now. It seems to work very well in our clinical practice. So there are studies underway looking at collecting data on this, and we're doing some studies at our institution. I can tell you from personal experience, this seems to work pretty well and give pretty accurate data. There are 2 big advantages, I think, of EMG technology. One is that EMG technology correlates the most closest with mechanomography, which is sort of for traditionally been the gold standard monitor we use. So its accuracy is probably better than some of the other technologies. Another big advantage is you can tuck the arm in at the side of the patient during the case. Unlike the TOF scan, we have to have the hand out, you can keep the arms tucked because you're measuring electrical activity. You're not measuring motion of the hand. So I think that's 2 big advantages of EMG technology. Next slide. Well, does this type of monitoring affect residual blocker outcome? There have been a number of studies over the years showing that if you use quantitative monitoring, you significantly reduce the risk of residual block. And you may be able to impact outcomes related to residual block too. I spoke earlier about the study we did in patients who are monitored with a quantitative monitor who had a lower risk of having these unpleasant symptoms of muscle weakness. This is a similar study we did. We took 185 patients that were randomized to either a TOF-Watch or a traditional peripheral nerve stimulator. We set up, designed very similar to our old study, but we were looking at that hypothesis was if we reduce the risk of residual block, we may be able to reduce the risk of adverse respiratory events related to this residual block. And what we found was in the patients who were monitored peripheral nerve stimulator, 30% of those patients had residual block versus only 4.5% of those who were monitored with quantitative monitoring. Next slide. When we looked at the period of time from transport from the operating room to the recovery room, patients who were monitored with a traditional peripheral nerve stimulator, 21% of those patients had severe hypoxemia and 11% of those patients had airway obstruction versus 0% in the TOF-Watch group. And then when we looked at the incidence, severity, and duration of hypoxemic events in the recovery room, they were significantly less in the group that was monitored with quantitative monitoring. So I think that we have some of this data that suggests that not only we can reduce the risk of residual block, but maybe some of these adverse events associated with residual block. It just all makes sense. Next slide. This was, I think, a really interesting study. It came from Mike Todd. Now, when he took over as chairman of Iowa, they had, shortly after he took over, they had several cases of reintubation in their PACU. And he was clearly convinced looking at these cases that it was related to residual block. So he really wanted quantitative monitoring, EMG monitoring in all the operating rooms. Now, getting people to change what they do takes a long time. So being a good researcher, he decided to study this. So basically, he started a series of educational lectures. And while this was going on, he did 5 separate survey samples over 2 years in which they recorded train-to-flow ratios in over 400 patients. Now, at the time they did the first survey in 2011, only half the people were using EMG monitor, 23% of people were using no monitoring at all, and about 31% of patients had residual block in their PACU. By the time they got to the 5th survey and these educational lectures had put in place, and we basically pushed this department to do it, 83% of people were using EMG monitoring, and the risk of residual block had been cut more than in half. But more importantly, during that period when they're using quantitative monitoring, they had no cases of reintubation in 2 years. So that's a really important clinical thing. Again, these are rare events, but they were able to eliminate the risk of reintubation in the PACU by using quantitative monitoring in the operating room. Next slide. So why don't people use quantitative monitoring? Given the evidence, you know, I mean, I just highlighted a little bit of the evidence here. Why don't people use them? And it really, if you look, only a minority of US anesthesia departments, probably 10 to 20%, even have these monitors. I think they sort of people got a bad taste in their mouth about them with these, with the first generation monitors like the TOF-Watch, because all the elaborate setup, the time to place, calibrate, you know, at that start of the case, we're doing 10 different things. The last thing we want to do is have to focus all our attention on getting a neuromuscular monitor hooked up. People perceive the results as reliable. There was a real learning curve to using the TOF-Watch. And I used to talk to my research assistants, and you really have to do about 50 of these before you really start getting reliable results. What I found in people in my group, they take it, they put it on, they push a button, they say, I don't believe these numbers, and they throw it in a drawer and never use it again. So there was a real learning curve. Again, the device wasn't simple to use. Surveys have shown that clinicians are overconfident in their knowledge and ability to manage the use of neuromuscular blocking agents. What I hear all the time is, I've been doing it this way for 30 years, and I've never had a patient who's had a problem. Well, I guarantee you've had patients who had problems. You just didn't know it. That patient who's developing pneumonia 6 days later is maybe your fault, but you're not seeing it. And finally, I think, you know, because people perceive residual block as a rare event, they probably think, well, why do I need to use a quantitative monitor? Again, the data is so overwhelming that residual block is happening in the majority of our clinical practices. Next slide. So how do we get people to change what they do? How do we get people to start doing things like using quantitative monitoring, routinely reversing patients, carefully dosing neuromuscular blocking agents? We really need guidelines, I think, from national organizations to get us to do this. If you look at what's happening around the world, basically it seems like most major countries in the world have guidelines about neuromuscular management. And many of these guidelines recommend the use of quantitative monitoring. Again, you'll find in Europe, for example, use of quantitative monitoring is far greater than it is in the United States. What does the American Society of Anesthesiologists say? Well, basically, they say nothing. They basically says basically our guidelines say there should be the availability of nerve monitoring when a muscle relaxant is administered. Why has our society remained so silent? I wish I could answer. I'm not quite sure, because I think we really have a great deal of data on neuromuscular management and outcomes now. That, you know, if you look at over the 40 years, the thousands of articles that have been published in this area, I think there's very good data. Why we haven't come up with some type of practice guidelines, I'm unsure. Next slide. So many people were frustrated that they got together and basically put together this consensus statement on perioperative use of neuromuscular monitoring. If the ASA wasn't going to do it, I think these people decided to get together and do it on their own, review the evidence and make some recommendations. And I think I'm just going to summarize, I think, the most important points that came out of this consensus statement. One is quantitative objective neuromuscular monitoring should be used whenever a muscle relaxant is administered. However, very importantly, the panel followed that with, they recognize that replacing conventional peripheral nerve stimulators with quantitative monitoring equipment will take time and education. During this interim period, the use of a peripheral nerve stimulator in any patient receiving a muscle relaxant is mandatory. I completely agree with that 100%. We've got to at least be using a peripheral nerve stimulant, ideally using a quantitative monitor. I think when these second generation quantitative monitors get more recognized and accepted, I'm hoping that people will start using these devices. We've got to get over the stigma, I think, of how difficult the TOF-Watch was to use. And some of these newer devices are much easier to use and we really should be, I think, using in our clinical practices. Again, subjective or clinical tests of neuromuscular blockade are not predictive of adequate neuromuscular recovery and are not sensitive to the presence of residual block. Their use should be abandoned. I completely agree with it. Again, if you look at surveys around the world, the main thing people use to determine whether they should pull the tube out is the patient holding their head up for 5 seconds. That just doesn't work. That professional organizations should develop practice standards and guidelines detailing how best to monitor and manage your perioperative administration of neuromuscular blocking agents. Couldn't agree with more. How many times I've seen a statement like that in the literature, I can't even count. But again, the ASA for some reason is resistant to doing this. And it was a view of the panel that the ideal quantitative monitor should be EMG device because a number of advantages, including what I talked about. Next slide. So in conclusion, what I say about residual block and neuromuscular management, we know that a high incidence of residual block persists in clinical practices with approximately 40 to 50% of the patients are being admitted to the PACU with objective evidence of residual block in most clinical practices. Again, the exclusion of this, if you have a clinical practice that's using a lot of Sugammadex or a clinical practice that's using a lot of quantitative monitoring, I think the risk is significantly less. We know from studies that have been published over the last 3 decades that if the patient gets to the PACU with residual block, there are higher risks for hypoxemic events, airway obstruction, postoperative pulmonary complications, prolonged PACU length of stay, and unpleasant symptoms of muscle weakness. So a lot of bad stuff associated with this, which if we want to optimize our patient care, do we want our patients getting to the PACU with these adverse events? And careful objective monitoring of neuromuscular blockade is essential in enhancing recovery and optimizing patient outcomes. Well, I want to thank you all for your attention today, and we'd like to now just open it up to any questions you may have for me or for Dr. Brull. Thank you.
So to start out, first question being, we have found that by using Sugammadex, we don't need to have, we seem to not have any issues anymore. Is there really a need for a monitor if we use Sugammadex and a PNS?
Yeah, I think, first of all, the first thing, you have to use at least a peripheral nerve stimulator. And there's an interesting study that came out of Japan where, 2 interesting things about Japan is everybody in the country gets Sugammadex because the government has approved it for everyone. And the reason is that they have no PACUs in Japan. So patients go right from the operating room back to ambulatory or back to their room upstairs. So they're able to convince the government to use Sugammadex in everybody. However, people in Japan don't use peripheral nerve stimulators. Monitoring has never been a part of the culture there. And you find there's very different cultures around the world in relation to neuromuscular monitoring. So they actually did a study and they looked at residual block in patients who got Neostigmine before Sugammadex came out and after Sugammadex came out. And they found that the risk of residual block was as high as almost 10% in patients who got Sugammadex if you did not use a peripheral nerve stimulator. So I think it's very important to at least use a peripheral nerve stimulator in patients. As far as quantitative monitoring, I think it's important to have quantitative monitor available because even when you use Sugammadex in clinical practices, I think there's times that we may not dose appropriately. One of the things is we oftentimes, and I see in our clinical practice, we're dosing our Sugammadex base. We have 2 twitches up here at the facial nerve. Well, that doesn't correlate with what's happening at ductal polysis. All the Sugammadex studies were based on responsive to ductal polysis. So you may see 2 twitches up here, but no twitches down here. So you may be giving too low a dose of Sugammadex to our patients. And I think another common practice I see is, what do people give? They give a bottle. You give 1 bottle of Sugammadex to everybody. So I think a lot of times we'll find that and a lot of our patients are obese, and we're not dosing really. The recommendation is to dose towards actual body weight with obese patients. So I think very often we underdose, which sets us up for a problem with residual block. So I think it's very important to have quantitative monitor available. So those patients you're not sure, wow, I gave them, and I hear this in our practice, I gave them a dose of Sugammadex and they still appear weak. I think it's important to have quantitative monitoring so we can assess those patients. When I talk on this topic, I say every department should have quantitative monitoring available. Ideally, it can, in every operating room. One of the most sophisticated dosing neuromuscular management practices I've heard is University of Washington. And what they do is they use Sugammadex and quantitative monitors. So what they do is they put quantitative monitors on everybody. And at the end of the case, if they have a train of 4 ratio of 0.4 or greater, they use Neostigmine. And they've shown that you can get almost all your patients back to a train of 4 ratio of 0.9 or greater within 10 minutes if you use Neostigmine, if you have a train of 4 ratio of 0.4 to 0.6. If it's less than 0.4 to 0.6, they use Sugammadex. So it helps them deter, actually they're doing this and they're studying this now to see if they can reduce their use of Sugammadex through the use of quantitative monitoring. So I think quantitative monitoring and Sugammadex can be used well together also.
Perfect. All right. Next question. Are you aware of clinicians that are using this in the PACU to document sufficient reversal in the event there's respiratory complication later in a patient's stay?
We actually do that in our clinical practice. One of the initial studies we did, we looked at patients with critical respiratory events in our PACU. And we looked over a 1-year period, and every time someone was having one of these events, they'd call my research team over it, and we run over as quickly as you could and document whether they had residual block or not. And what we found was 90% of the patients who were having critical respiratory events in the PACU had train of 4 ratios less than 0.9. Nearly all the patients had residual block, compared to we had a control group, which we looked at, which the risk was about 25 or 30%. So in our PACU, anyone who's getting in trouble in our PACU, the first thought is residual block, and we run over there and check that. So that's still our practice nowadays. If someone is having any type of trouble in the PACU, we basically look whether they have residual block or not very quickly to help us determine what's going on. And again, the majority of these patients do. And our standard practice now is just to give Sugammadex in those patients.
Yeah, can I chime in here as well? I totally agree. And when you're talking about monitoring in the PACU, there appear to be 2 limitations. Number one is, what monitors are you going to use in the PACU? Well, there are 2 options for that. Most of the university hospitals or private practices have by now gone with a single type of monitoring. So they would have GE or Draeger monitors, both in the operating room and in the PACU. So using a modular unit that you can plug into the PACU should be very simple. On top of that, you now are starting to have some of the portable neuromuscular monitors. And certainly you have access to peripheral nerve stimulators if you're going to use Sugammadex. So I think that should be one of the responses. The other is, I hear often that clinicians worry about testing patients who are awakening or awake in the PACU for fear that they will hurt them and, somehow make them remember unpleasant things. It's interesting, we did studies on volunteers who were unpremedicated, and the visual analog scores on a scale from 0 to 10 for currents up to 70 milliamps are in the 6 to 7 range. So they're not that painful. Number one. Number two, you don't need to use 70 milliamps or even 60 milliamps. There are several studies that have shown that you can use reliably a train of 4 ratio at a current of 30 and 40 milliamps, and patients will hardly feel it. Additionally, patients in the PACU are post-anesthesia, so they still have some anesthetic on board, some amnestics on board. So very few of them, I think less than 90% of them, will even remember when asked, will even remember that they were tested in the PACU. So I don't think that that's that shouldn't be the limitation. I mean, the bottom line is that we should, if we expect that patients have residual block in the PACU, they should be tested.
And I think it's something so easy to roll out very quickly in patients. If someone's in trouble in the PACU, it's very easy. Test real quick, find if they have it, and then you can move on to the other things.
Yeah.
That's what I think. That's what our practice, where people really realize some of the value of quantitative monitoring. That was sort of a starting point in our. And that's why I said, if you don't think residual block is a problem, keep a top quantitative monitor in your PACU, and you'll find quite often that they'll change your beliefs very quickly.
Yeah.
Great points. So here's another question. The tetragraph appears to have 4 electrodes, cathode and anode, 1 recording over the APN, and 1 reference. Where's the ground electrode?
Dr. Brull, I'll let you answer that, but you're far more expertise than I.
Yeah, as a, I guess, disclosure of conflicts of interest, the tetragraph, I've helped develop it, so it's my baby, so to speak. So that's the conflict of interest here. For EMG, we do not need a ground electrode. So we do not have a ground electrode like you would have had in the older types of EMG, like the GE machine that Dr. Murphy has shown you. So there is no ground electrode.
Perfect. Thank you. Do you think there is a role for quantitative monitoring in the ICU setting on ventilated patients? Has there been any work published on this topic?
Actually, none that I'm aware of. Actually, it's an excellent question, and I have some ICU colleagues who have run down to the operating room and grab quantitative monitoring when they've had questions. It's I think a very fertile area for research. But I don't know, Dr. Brull, are you aware of any studies?
Yeah. So a couple of things that seem to be different in the ICU setting. First of all, patients who are in the ICU will probably require longer-term neuromuscular block. So we all remember in the 1980s and early 90s when postoperative residual myopathies were a real problem in patients, in the ICU patients who received neuromuscular block for days on end. So we have to remember that if we do paralyze patients in the ICU, they need a period of vacation where they can regenerate the receptors. So that's the one caveat. The second is that unfortunately, a lot of the patients in the ICU are fairly edematous. So that makes the neurostimulation a little bit more difficult. In other words, you have to use higher currents to penetrate the resistance that the edematous tissue provides. And they may be febrile. And if they're febrile and they have some, and they perspire, then the electrodes won't stick very well and they will decrease the effectiveness of neurostimulation. So there are real limitations to the ICU patients. As far as I know, there are 2 ongoing studies in Europe that are currently looking at the use of objective monitors in ICU patients. And hopefully we will have the results in the next 6 months.
We actually did some early studies in cardiac surgical patients. So when they got up to the ICU, this is a time when we're still using pancuronium. And we found that at the time the nurses were ready to wean and extubate the patients, the average train of 4 ratio was 11%. What's interesting, when we switched our practice to using rock uranium for heart patients, within about 2 weeks, I had a call from the head ICU nurse, and she came to me and said, "Whatever you're doing, stop it." I said, "What do you mean?" Our patients are complaining. They're moving around. They're waking up. Yeah, they loved it when the patients were paralyzed and laying there. They couldn't ask any questions. And they couldn't complain about pain. It took a while. Again, we talked about how difficult it is to get people to change practices. Now they obviously accept it. But it took a while for them to accept the idea that, hey, you have to sedate these patients. You can't just leave them there paralyzed like we were before.
Yeah, I agree.
Perfect. And we are getting close to the hour here, and I want to be respectful of people's time, but our panelist had mentioned prior to this call that they'd be willing to stay here 5-10 minutes afterwards to answer any further questions. So if you do want to jump off, please feel free, but I do have one more question here. Can you comment on the cost to implement quantitative monitoring and your experience in justifying the incremental expense in your department? BIS, NIRS, FlowTrack are just some of the technologies that are constantly being scrutinized. Hate to implement something new only to have the battle to retain its use. Thoughts?
Yeah, well, I think the important thing to look at with any type of monitoring is it going to really impact outcome? And I think there's so much data now showing that residual block has these downstream effects. The patients of residual block not only have more trouble in the PACU, but if we looked at them now, there's accumulating evidence these patients are having a higher risk of postoperative pulmonary complications like pneumonia that may significantly prolong PACU length of stay. So I think making a case that residual block is a very important patient safety issue that has these effects downstream, not just in the operating, but we're looking at these patients following afterwards. We can talk about things like increased 30-day readmission rate and increased unplanned ICU admission, increased risk of postoperative pulmonary complications. It's clearly documented this is, I think, a very important patient safety issue, and that by appropriately managing neuromuscular blockade, we can reduce some of these downstream effects, which are very expensive for hospitals. And I would say, for example, we use BIS monitoring in probably 50 to 75% of our cases. Where's the outcome, really the outcome data showing that by monitoring that we're really changing much of anything? The incremental cost I mentioned is pretty similar to using a quantitative monitor. I think the evidence is much better that if we can reduce residual block, that we can really enhance these patient outcome measures. And I think, Dr. Brull, you pick up any anesthesia journal, it seems every month there's an article related to one of these issues. Dr. Brull, I don't know what your thoughts are.
Well, I obviously agree with you 100%. There are actually some studies that have shown that the duration of hospitalization is prolonged by 3 days. So I think that people will have to make their own pharmacoeconomic studies as to what it translates in their own practice in terms of dollars. Because, 3 days at Mayo Clinic may not be the same thing as 3 days at a different hospital. But clearly there are downstream effects that are very, very important. And we always focus on the money, and we never think about what the patients. Now, it reminds me, there was a study probably 25 years ago that asked patients how much they would be willing to pay not to suffer from postoperative nausea if they had to pay from their own pocket. I think that the answer was back then $300. I think it would be fascinating to do a survey of patients and ask them how much they would be willing to pay out of pocket not to have these postoperative residual complications. So.
And I think residual block has been associated with so many different adverse outcomes. Even talk about feeling nauseous, feeling paralyzed. How much would people pay to not feel that? I think when people say they feel bad after surgery, a lot of feeling bad after surgery is related to residual block. People remember it, and it's fun every time. Almost always when I give this talk, someone will come up to me in the audience, one of the anesthesiologists, and say, "I very distinctly remember that feeling, and it is terrible."
All right, thank you. Do you think that patients who are having CRE in the PACU have been misdiagnosed as having excessive opioids on board? There has been a big drive to do more capnography monitoring in the PACU to detect respiratory compromise. Often the first assumption is OIRD, and we treat with Narcan, but sometimes with limited response leading to reintubation. Perhaps we have been missing the boat.
I think that's exactly, that comment's exactly right. And that's what, when we started that initial study I talked about, we almost always, these critical respiratory events were, like I said, because the patient, 400 pounds, morbidly obese, sleep apnea, we gave him a little bit too much opioid. There's still some gas hanging around. Oh, we gave him maybe too much Versed during the case. We don't often, to me, the number one thing to rule out is residual block. And I think that's what's one of the nice advantages. We have all those things we think about. We're going through our differential in our head. Put a quantitative monitor, you can very quickly and easily rule out residual block. So that's one of the things that's easily rule out. But what we found is, I can't tell how many patients who are having those critical respiratory events. We put a quantitative monitor. Ooh, the train to 4 ratio is 0.4. Give them Sugammadex, how quickly they get better. We've probably all seen that practice too, when even when we don't have quantitative monitoring, they're struggling in the PACU, we give them a dose of Sugammadex, hey, suddenly they got better. We recently had someone who was struggling in the PACU for a couple of hours, and someone came in, a new attending, first he did walked over and gave Sugammadex, and the patient immediately got better. So I think it's a very common cause of these critical respiratory events. And again, it's been shown across multiple studies that the single biggest predictor of these critical respiratory events in the PACU is residual block. So it should be the first thing that you rule out. Then I look at the other things going down differential. I think we have such a fear of opioids as a specialty. That seems to be number one on in our minds, but I think it should be residual block.
Yeah, so if I could just, a couple of additional points. If you think about the milieu of the postoperative patient, number one, they're post-surgical, so they're going to have pain. So they are going to get opioids. They get opioids, they will get hypocarbic, acidotic, which will potentiate the residual neuromuscular block. They're cold. That potentiates the neuromuscular block. They may be given some antibiotics postoperatively. All of these will potentiate whatever residual neuromuscular block. So all of a sudden you have a patient who in the PACU, right in the operating room right before extubation, they were breathing just fine. And now 10 minutes into the PACU, they crashed because all of these factors have potentiated the residual block, and now they have significant weakness.
Great, thank you. So we're a little bit after the hour. I want to thank Dr. Murphy and Dr. Brull for joining us for this webinar. It was an amazing presentation. There are a few additional questions and more coming in. So what we discussed prior is for our panelists to answer those questions offline and provide those in that follow-up communication that will come. As well as any questions that come in the later session today. But I'd like to thank everyone for their time. On behalf of Synzyme, Dr. Murphy and Dr. Brull, thank you so much for joining today.
Thank you.